do it.
Good morning, good afternoon, good evening to you all. My name is Renee Stafford. I am the Deputy and Technical Director for Momentum Safe Surgery and Family Planning and Obstetrics. It is my pleasure to welcome you to today's webinar in commemoration of the 2022 International Day to End Fistula. We have a wonderful group of presenters today who are really ready to share their insights and experience with all of us on the importance of rehabilitation and reintegration as part of holistic fistula repair. Next slide, please. We are very pleased to be able to provide French interpretation today for this webinar. If you would like to listen in French, please follow the instructions on this slide as seen here. Next slide, please. I would briefly like to go through today's agenda with you so that you know what to expect. For a detailed copy of the agenda and a link to the speakers' biographies, please go to a link that is now placed in the chat. Today, we'll talk a little bit just about introductions and housekeeping. Please, we would like to ask you to place any questions you might have in the Q&A or in the chat, but if you can, please place them in the Q&A. That will be easier for everyone to keep them together. We will be having a recording of this event, and you will receive that after the presentation. Also, at the end of the presentation, you will be given links to all of the various speakers' organizations, as well as other useful links, and a link to a survey that we would like you all to complete. You will hear a welcome address from our CEO of Engender Health, goodwill messages from USAID and UNFPA. You'll hear presentations on physiotherapy and rehabilitation, social immersion, economic empowerment, counseling and follow-up for community-based prevention of fistula recurrence, and Safe Mother Ambassadors. You'll hear a commentary from the director of the Momentum Safe Surgery and Family Planning and Obstetrics programs. We'll have a question and answer session, and we'll talk about a rehabilitation and reintegration working group, and then we'll have a thank you and closing. Thank you so much. Next slide, please. I'd briefly like to introduce our Engender Health, Momentum Safe Surgery and Family Planning and Obstetrics, USAID and UNFPA speakers. As you can see here, you will hear an address from Tracy Baird, the CEO of Engender Health, from Aaron Milkey, our USAID partner, Bridget Asiama from UNFPA, Vandana Tripathi, the director of our program, EMA FM, our director for fistula, and myself. Thank you. Next slide. And now we'll hear from Tracy Baird.
Greetings to all. I'm Tracy Baird, President and CEO of Engender Health. I'd like to acknowledge our honored speakers and guests, including representatives from USAID, UNFPA, ministries, and many leaders from academia, clinical practice, and civil society. It's an honor to welcome you and everyone to this event, recognizing the International Day to End Obstetric Fistula, and to speak to a large gathering of key players in the fistula world to express our support for the global initiative to end fistula by 2030. It is also exciting that the theme of this year's webinar is the importance of rehabilitation and reintegration in holistic fistula care, as it fits so squarely with Engender Health's priorities and core values. Engender Health is committed globally to advancing sexual and reproductive health and rights and gender equality. We envision a gender equal world where all people achieve their health and their rights. And to achieve this vision, we implement high quality, gender equitable programs that advance sexual and reproductive health and rights, and we address maternal health and gender-based violence. All of our work is guided by 5 core values. Reflection. We question, challenge, learn, and adapt. Inclusion. We're committed to equality, justice, and leaving no one behind. Integrity. We are principled and honest, and we walk our talk. Respect. We value the wisdom and agency of our collaborators and appreciate our differences. And finally, transformation. We seek bold ideas and opportunities to innovate for progress. Engender Health's work on female genital fistula prevention and treatment embodies our organization's mission. Treating fistula requires the attention and expertise of fistula surgeons and other clinical partners, but ending fistula also requires that we give equal or even more attention to prevention. This includes access to quality maternal health services, especially emergency obstetric care and safe cesarean section. And of course, this includes advocating for and building policies and programs so that women and girls meet their full potential, including promoting girls' education and ending practices such as child marriage and female genital cutting. One intervention area that's seen less attention has been rehabilitation and reintegration of fistula survivors. Treating the injury while relieving the burden of incontinence presupposes that the survivor is now okay and can return to normal life. But we have seen that this is not always the case, as emotional injuries and economic hardships are harder to determine and treat. The rehabilitation and reintegration focus of this webinar to bring attention to this critical component and ensure that it is mainstreamed into routine, holistic fistula programming is highly welcome and needed. Engender Health is committed to working with regional bodies, national and local governments, and local partners to support and advance these goals, as I know you are too. Thank you for joining us in these efforts and enjoy the webinar.
Well, thank you very much to our president, Tracy Bird. We'll now invite Erin Milkey from USAID to give us a goodwill message. Erin, over.
Thank you, and greetings, everyone. I'm pleased to represent the United States Agency for International Development as we mark the International Day to End Obstetric Fistula. Since 2004, USAID has supported efforts to prevent and treat fistula in low-resource settings around the world. USAID support is enabling the world to make enormous progress towards ending fistula. As of May 2022, USAID has supported 57,500 fistula repairs in sub-Saharan Africa and South Asia, and trained over 400 fistula surgeons and more than 32,000 other health workers around the world in skills related to fistula prevention and treatment. On the prevention side, from 2013 to 2021, the Fistula Care Plus project provided more than 1.5 million family planning counseling sessions, and these voluntary family planning services resulted in more than 1 million couple years of protection in Bangladesh, the Democratic Republic of Congo, Niger, Nigeria, and Uganda. Family planning is not just for prevention of fistula, but a key component of women's post-repair care to enable the healthy timing and spacing of pregnancies following fistula repair. And in October 2020, USAID awarded the Momentum Safe Surgery and Family Planning and Obstetrics project, implemented by Engender Health as the new flagship global project related to surgical safety, including for fistula prevention and treatment. USAID, through the Momentum Safe Surgery Project, continues to ensure that this debilitating condition for women is addressed through mechanisms that ensure a holistic approach towards restoring dignity among women affected by fistula. While a successful repair can be life-changing, for women affected by fistula, there remain additional concerns, especially for those who have lost their self-esteem, livelihood, and families. Therefore, this calls for a holistic approach through a set of interventions that address the complete woman and not just closing the fistula. This holistic approach includes the need for a rehabilitation and reintegration strategy in managing interventions. Therefore, USAID is happy to see that this commemoration of the International Day to End Obstetric Fistula focuses on this important issue, and to hear from implementing partners and other global and local organizations on their efforts to support such strategies. Throughout its investments in fistula care, USAID has supported a holistic health systems approach, linking expanded fistula treatment to efforts to prevent fistula and comprehensively support the women who have suffered from this condition. Through the USAID-funded Momentum Safe Surgery in Family Planning and Obstetrics project, more attention is being paid to building local capacity for rehabilitation and reintegration as a crucial part of this comprehensive care strategy. Ending fistula also requires cross-cutting interventions to improve women's health, strengthen gender equity, and address contributing factors like early marriage, female genital mutilation, and gender-based violence. USAID supports programs addressing these issues in partnership with governments and communities across multiple regions. The world hopes to end fistula by 2030. On behalf of USAID, we thank all the participants today for their efforts to achieve this goal. And now I'll hand it over to Bridget Asiyama from UNFPA.
Thank you very much, Erin. Greetings, everyone. I bring you warm greetings from the United Nations Population Fund. It's a pleasure to address the solidarity message to you at this webinar on the important topic of the importance of rehabilitation and reintegration in holistic fistula care. Monday, May 23rd will mark the 10th annual commemoration of the International Day to End Obstetric Fistula. The day is commemorated to raise awareness, intensify actions, strengthen partnerships, and mobilize support towards ending fistula in the broader context of improving the lives of women and girls. This year, the theme for the day is End Fistula Now, Invest in Quality Healthcare, Empower Communities. It is a call for greater investments to improve quality of care for maternal health, for fistula prevention and holistic treatment, including geographical and financial accessibility, and underscores the critical role of empowered communities in addressing sociocultural, political, and economic determinants that impact maternal health, sexual reproductive health, reproductive rights, and rehabilitation and reintegration of fistula survivors. When the global campaign to end fistula was launched in 2003 by UNFPA and partners, fistula was a hidden and neglected epidemic, and the global response matched the situation. Since then, and through the relentless efforts of UNFPA and partners around the globe, much progress has been made in the prevention, treatment, social reintegration and rehabilitation of survivors, and global advocacy to end the condition. Now in 2022, we aim towards achieving the global goal to eliminate the condition by 2030, as called for by UN member states in a unanimously adopted resolution in 2018. This further recognized fistula as a human rights, development, and public health issue. With only 8 years to achieve this global vision, there are still hundreds of thousands of women and girls living with the condition, approximately 500,000 cases we know of, with new cases occurring annually. Fistula is an indicator of poor quality of care and a glaring outcome of existing gender and socioeconomic inequalities. Unfortunately, many countries that are facing the challenge of obstetric fistula are also facing an increasing challenge of iatrogenic fistula, emphasizing the need to address the gaps in quality of care. Despite a clear need for holistic fistula services, Most services are surgically based with little complementary or follow-up care. Women and girls, including those with fistula, have a right to a continuum of care that is of high quality, ethical, and sustainable, ensuring their rights and addressing the social determinants of health. Beyond surgical repair, the rehabilitation and reintegration for fistula survivors, tailored to their needs, is key to help them thrive, transform, improve their quality of life, and contribute to their communities. Whilst various interventions have been implemented across the globe by governments and local partners, with support from UNFPA, USAID, and many Campaign to End Fistula partners, the rehabilitation and social reintegration pillar in the campaign continues to lag behind. This is most unfortunate. UNFPA has supported the development of national strategies to end obstetric fistula, has supported the functioning of national task teams to also monitor and coordinate programs to ensure that we get the outcomes that we want to end obstetric fistula. Over the last 2 years, however, the COVID-19 pandemic, whilst causing a disruption in our community of practice on fistula and maternal health, also caused a disruption in essential SRH and maternal health services. It slowed down implementation of fistula programs, including treatments and follow-up and social reintegration programs. It has also delayed the implementation of development programs which contribute to the prevention of fistula, such as programs to end child marriage, with the likelihood of increased cases of obstetric fistula. In view of this, the value of this important webinar organized by Engender Health and Partners, which has brought together partners and stakeholders to discuss, learn, share, and identify strategies and solutions to enhance holistic fistula care, cannot be overemphasized. In 2021, UNFPA and the Campaign to End Fistula developed and released an updated global guidance on clinical management, program development for obstetric fistula and other female genital fistula. The guidance is a useful resource which details new approaches and strategies to end fistula by 2030. It's based on current evidence, best practices, and lessons learned from over a decade. UNFPA, in its new strategic plan of 2022 to 2025, reaffirms its commitment to lead and support the global campaign to end fistula by 2030. The plan aims at ending preventable maternal deaths, ending unmet need for family planning, and ending gender-based violence and harmful practices. We will, through the commemoration of this year's International Day to End Obstetric Fistula, reflect on progress made, raise awareness, and generate new political and financial support for the campaign. We'll be supporting various advocacy engagements in countries around the globe at various levels. I'm pleased to inform you that UNFPA relaunched the website of the Campaign to End Fistula as a new interactive advocacy platform aimed at further raising awareness to generate support and action to end fistula. UNFPA stands in solidarity with and acknowledges the significant contribution of Engender Health to the Campaign to End Fistula. It is through the collective efforts of all of us that we will improve the lives, dignity, rights, and well-being of women at risk of living with or recovering from obstetric fistula. Now is the time to consolidate the limited resources available, rebuilding this and sustaining the gains made in past years, and to embrace evidence-based approaches to end obstetric fistula. UNFPA applauds Engender Health for organizing this webinar, and I wish us fruitful outcomes which will contribute to strengthen rehabilitation and social reintegration for holistic fistula care. Thank you.
Thank you very much, Brenda from UNFPA. We appreciate the speeches given by Brenda, our president, Erin and Brenda. And for now, I will be recognizing participants and from different parts of the world. I'm happy to see that we have very many participants in this event. It is quite impressive. So allow me to quickly recognize the countries represented here in alphabetical order. We have Burkina Faso, we have Canada, we have Democratic Republic of Congo, we have Ethiopia, we have France, we have Ghana, we have India, we have Kenya, Malawi, Mali, Mozambique, Nepal, Nigeria, Rwanda, Saudi Arabia, Senegal, Southern Sudan, Switzerland, Tanzania, the Netherlands, Uganda, United Kingdom, and of course, the United States of America. You are all welcome. I will now briefly introduce our esteemed speakers in the order they will be presenting. More details about them are already in the event agenda and speaker biographies documents that is shared, like Renee noted. So I will give a brief introduction on it. The first presenter is Jessica Mckinney, a physical therapist, educationist, and consultant for MAMA LLC. She will be speaking to us on physiotherapy and rehabilitation. And then she'll be handing over to Mustafa Diallo, a former country program manager for Fistula Care Plus in Guinea. He will be speaking to us on social immersion. Mustafa will be handing over to Brenda Msangi, the CEO of Comprehensive Community-Based Rehabilitation in Tanzania, and she'll be speaking on economic empowerment. Thereafter, Brenda would hand over to Yemisi Bashoro John, a professor of adult education and president of the Institute of Social Works of Nigeria, who will be speaking to us on counseling and follow-up for community-based prevention of fistula recurrence. Following her will then be a tag team duo of Meselek Seyum, the head of Healing Hands of Joy, and Alima Abba Miki, a Safe Motherhood ambassador and graduate of Healing Hands of Joy. They will be presenting on the topic Safe Motherhood Ambassador and giving a personal experience. They will then hand over to Vandana Tripathi, the director of Momentum Safe Surgery Project, to provide some commentary on implications of Momentum Safe Surgery in family planning and obstetrics. So now you know the speakers and they are ready to deliver. We request that they please ensure that you keep to the allotted 8 minutes per presentation. And once you are finished, please hand over to the next speaker by inviting them to present. With that, I invite Jessica Mckinney to present. The screen is yours, Jessica. Next slide.
Thank you very much. I'm excited to be here and talk with you about physiotherapy in the context of fistula care. May we go to the next slide, please? MAMA LLC is a small partnership formed in 2017 with my colleague, Dr. Laura Kaiser, through which we direct our work in physiotherapy and public health. Our focus is on maternal and women's health needs. We work with humanitarian and professional organizations, educational institutions, and for-profit entities in the areas of education and training, research, and health promotion and advocacy. Next slide, please. Since we started working together in 2009, we have pursued capacity building work in physiotherapy and fistula care. We have conducted and created templates for site assessments. We provide in-person and remote clinical training and support. We have advised and participated in research. One significant output is an open access training guide for health workers, a project generously supported by Engender Health and USAID, the cover image of which is shown to the right-hand side of this slide. This is a 200-page guide to physiotherapy and physiotherapy-informed care, including health education, evaluation, and treatment suggestions. It is available in French, Swahili, Portuguese, and English at www.themamas.world/training guide. We also give great credit to our colleagues at Pansy Hospital and foundations for working closely with us since 2013. Next slide, please. We have pursued this work because physiotherapy is an essential health service. Physiotherapy rehabilitation focuses on movement and function, quality of life, and supports physical, psychological, emotional, and social well-being. It is estimated that 92% of the global burden of disease is related to causes requiring some level of physical rehabilitation. Yet only 50% of countries can provide rehabilitation to approximately 20% of those people in need. The numbers are very stark in sub-Saharan Africa, where there are only 1/2 0.5 rehabilitation professionals per 10,000 people. Next slide, please. Physiotherapy is important in fistula care because there are many comorbid conditions women experience pre and or post fistula repair that affect function. These can include incontinence, pelvic and musculoskeletal pain, and sexual dysfunction. One of our research efforts involved administering the World Health Organization Disability Assessment Schedule, a validated survey tool that quantifies disability status, to women with fistula in Rwanda and the Democratic Republic of Congo. This tool identified high levels of disability among 83% of the women involved. Disability affected physical, mental, and social domains. One of the common objections encountered in our work is that evidence is lacking to support physiotherapy in fistula care. In response to this, we conducted a systematic review of the limited literature available and documented that while it is poorly studied and the workforce is very limited, physiotherapy capacity is feasible and desired by patients and clinicians alike. Next slide, please. As mentioned previously, Pansy Hospital has been an incredible partner for nearly 10 years. We work especially closely with Dr. Kenny Raha and Dr. Rachel Kinja. A few highlights of the work include a model of task sharing and task shifting for various aspects of rehabilitative care involving surgeons, nursing staff, social workers, and physiotherapy. Group exercise sessions have been developed to promote shared social experiences and address capacity limitations. Targeted one-on-one physiotherapy is provided for people with the most significant rehabilitation needs. Staff and hospital leadership perceive the program to be valuable and desire further development of physiotherapy services. Next slide, please. Other ways success or the impact of our work is evident is in the peer-reviewed publications that were highlighted previously about disability and the systematic review. We have also contributed chapters on physiotherapy and fistula, including for the most recent UNFPA publication. The training guide I mentioned earlier has been downloaded over 100 times and accessed in 22 countries. It serves as a foundational resource in training and program development in several countries. Next slide, please. In conclusion, we recommend physiotherapy-informed care be integrated in fistula care more broadly. That level of function and disability can be measured and monitored using tools such as the World Health Organization Disability Assessment Schedule, that to do so provides an opportunity to decrease long-term costs of medical management, reduce disability, and improve the quality of life for women with or recovering from fistula. Next slide, please. We strongly encourage approaching physiotherapy and other rehabilitative care as essential health services. Doing so requires acknowledging that significant workforce limitations require employing many strategies to scale up rehabilitative care. These include task shifting, task sharing, and a significant investment of both time and financial and other resources. Thank you for your attention. And with that, I'd like to invite Mustafa to join us for the next section of the presentation.
Bonjour, bonsoir.
Hi, hello everyone.
Next slide, please. Engender Health implemented the USAID Fistula Care project from 2007 to 2013 in Guinea. This project holistically addressed the root causes of obstetric fistula, including unavailability of quality health services, the burden of transportation, early childbearing, poverty, gender discrimination, poor governance. This project had 4 interrelated components: fistula prevention, fistula treatment, local democratic governance, and reintegration. My presentation relates to a community approach to reintegration, the social immersion of women after the surgical treatment of their obstetric fistula. Next slide, please. Why a social immersion program? In 2007, in implementing the USAID Fistula Care Project and Gender Health in collaboration with the Ministry of Social Affairs and Women Promotion and the Community Council of Kishidegu, conduct in-depth interviews with women who had received fistula repair services in the district Kishidegu Hospital. Many women had experienced profound emotional distress and a dramatic decline because of their fistula. In Kishidegu, Gender Health therefore initiated a social immersion program which offered psychosocial therapy to women who had experienced isolation. The program was successfully replicated to other subsequent projects. Next slide, please. Program description. Gender Health has forged strategic alliances with local community councils to foster ownership of project activities and maximize impact. That's why the mayors and their colleagues helped identify volunteer host families within their respective administrative areas. The program assigned each woman who accepted and who discharged from hospital to a volunteer host family for 2 to 3 weeks. The role of the host family was to gradually involve the visiting woman into family activities such as cooking, eating meals together, shopping, participating in social events, etc. Next slide. Next slide, please. Host families provide a supportive, caring environment as visiting women recuperated. After being socially isolated, sometimes for years, they could once again participate in family life. During the stay, host families were honored through several special visits from the mayors or their representatives, along with the rural radio stations. Host families were interviewed and their messages were broadcast to sensitize communities and combat the stigmatization of women with fistula. For most families, the main reason for volunteering was the satisfaction they received when helping women recover and reintegrate into society. Next slide, please. 2 studies were conducted on the Guinea Social Immersion Program, and Gender Health in 2015, and the Islamic Solidarity Fund for Development in 2016. They found the following, quote, women reported a very good experience with the social immersion program. They lived with host family where they felt at home. They demonstrated improved confidence and regained their self-esteem. The program considerably shortened the duration of the reintegration process into the social environment. This program successfully facilitated the transition between the hospital and their village. Host families expressed sincere satisfaction with their experiences. Compassion and solidarity led them to volunteer as host families. All of them have expressed interest in hosting women again in the future, end quote. Next slide, please. The Islamic Solidarity Fund for Development documented and published the Guinea Social Immersion Program as a success story in May 2017. According to the study report, quote, the testimonies of treated women demonstrate how the project transforms their lives. From living away from her community, each woman is now back to her. She always wants to be in the heart of her family, pursuing her own livelihood and taking part in everyday life, end quote. Next slide. Some recommendations for strategy replication. First, important to develop strategic alliances with the community and fruitful partnership with all stakeholders. They are critical to maximizing impact. Two, during the pre-implementation phase, formation of an inclusive steering committee. Members should include government entities at all levels and the community councils. Three, foster participation and ownership. They should be the two pillars of the strategy. And then implement the step-by-step social immersion strategy as per program description. Next slide, please. Conclusion. It's a matter of common knowledge that a long isolation and an excessive stigmatization can cause intense psychological disorders. Therefore, surgical repair of the fistula is not enough to return to the normal life in society. For these women who live at the rhythm of community interrelation, the exclusion from social activities is more painful than their urinary incontinence condition. They need psychosocial therapy to return to a normal life. The social immersion program gives them the opportunity to relearn life in society through action. It's based on the values of solidarity, mutual aid, and sharing of the society. In implementing momentum safe surgery in Guinea Gender Health, we'll include the learning from this work as part of strengthening holistic fistula care. Next slide, please. This slide is about a mayor visiting a host family. The honor of receiving such a visit from dignitaries such mayors gives the host family great pride and motivates the community to support the initiative. Thank you. Next slide. Okay,
I will now invite Brenda Msangi to take on the screen. Brenda, over to you. Thank you, Mustafa. Brenda, if you're mute, fine.
Hi, good afternoon. I'm not sure if you can hear me.
We can hear you, Brenda.
Yemi, can you hear me?
Yes, we can hear you, Brenda.
Brenda, go ahead. We can hear you.
Great. Okay. So thank you very much. Lovely to be here. Let's go to the next slide. So a bit about CCBRT. We're a healthcare organization, and we are on our own journey to become a social enterprise. Our main mission is to serve the most vulnerable in Tanzania. And we do that through two ways. One, by providing specialized healthcare services, which is clinical services, but also we have development programs. In terms of clinical services, I have to mention that fistula is one of our clinical services that we provide. And we are also the largest provider of holistic care for fistula. And also not that we're only providing treatment, but we're also accredited by FIGO to train other surgeons to become fistula surgeons. So in terms of development programs, I will focus on Mabinti Center, which is a specific project for ex-women who had fistula. Next slide, please. So as I said, Mabinti Center, it's purely to empower ex-fistula patients. Mabinti is actually a Swahili word, which means girls. So this is meant to empower these women who were treated fistula at CCBRT. It's a 4-month intensive training program, and we do all sorts of things, including screen printing, sewing, batik, beading and crochet, but also we do entrepreneurship skills so that when they finish, they can start up their own small business. Once we have trained them, some of them actually we employ them to become trainers for new batch of trainees. So it's a unique financial model to support the center as well. So as I said, we're a social enterprise. The revenue that we get from the items that they produce, we have a training side and also production side. For those items that are produced, we sell them, and the income that we get also goes to support the treatment of women with fistula. Next slide, please. So why do we have this center? Again, it's a center of 12. Every year we take a batch of 12 women. Now, we all know the background most of these women come from, right? And the survey that we did from our own patients that we treat, more than a third of them did not have a formal education. And for those who received formal education, 45% of them were educated up to primary level only. Now, the consequence of low education, it really limits them a chance to be employed, or we say gainful employment. So Mabinti Center provides skills to enable the graduates who graduate from this program to engage in economic activities and again, restore their dignity. Next slide, please. So, of course, the challenges are always many, but I'll try to limit some of the challenges that we face. During COVID time, I'll start there. During COVID-19, we had to stop recruiting new trainees. I think it took us about a year that we couldn't do the program. So we were continuing with production, but not new trainees because of COVID. We had to reduce the market of our products overseas because we also do sell the products of the ladies outside Tanzania, in Europe and the US as well. Again, the other challenge is resources, availability of funding to recruit a cohort and conducting training. Sometimes it can get really limited. And then the other challenge is that to actually recruit new trainees, especially when they get treated, they go back to their villages. So recruiting women, and sometimes they have to seek permission from their family members to join as well, because they have to be with us for 4 months. So that's the other challenge that we foresee with them. The other challenges is when they go back again to their villages, because we do provide them with startup kits. They fail to get materials because either it's very expensive because they have to go to towns to go and access these materials, but also they cannot access capital to grow their business. So they cannot expand their business due to lack of capital. They cannot access capital. The other thing is societal pressure. I mean, they then have this expectation that, okay, so now you are trained, so, you know, we depend on you to generate income. So that, again, it comes as a society providing them pressure once they go through the training. Next slide, please. So impact, I've tried to capture some of the impact of this particular program. Up to December last year, we have trained 163 women. As I speak, we have a new cohort. We will have 2 cohorts this year. So we have now 12 women undergoing the training. We have psychologically improved their health and really giving them hope to go back to their community and to their society. Reintegration is always a challenge, as you know, so this as well really helps to go back to their community. And then it creates self-confidence to them because most of the time they were really outcasted. So this has shown a lot of giving them confidence when they go back. And then it really changes attitude in community towards women with fistula. And again, it's a source of revenue, so it really improved family livelihood. Next slide, please. So I tried to share one of the real life stories that these women, we do make follow-up after they get trained, they receive training. The two ladies there, the one who's standing is actually a trainer at the moment, but also she used to be an ex-fistula patient. So she visited one of the trainees who graduated, and we provided a startup kit, which is a sewing machine and some of the materials. So now every month she has an average profit of about $65. And that really, she feels human again, and she's accepted back in her community. So not only the financial side of things, but also the whole part of the community welcoming back her. So that really is one of the impacts that I wanted to share. Next slide, please. So I'll have some recommendations. Again, fistula, we still need to educate people about fistula. So fistula is still a myth, and we need to demystify it. Again, we need to continue with intensive community awareness, raising, and also on causes, and that it's a treatable condition. As a CCBRT, the way we've managed to get women to come for treatment, because now we do about 500 surgeries a year, 500 to 600 surgeries a year, is by using ambassadors. And ambassadors are anyone really in a community. We have more than 500 where we use them to spread the word of fistula, to educate the communities. And when they come across these women, we have a dedicated call center here at CCBRT. So they give us a call, and then we send transportation money via mobile phone. And again, that's one of the innovative ways we use to get these women. So once they get these women, they put them on a bus or a train or whatever mode of transportation, and then we go and pick them up and bring them to the hospital. So this has really created, broken a lot of barriers in terms of awareness, but also breaking the barrier of cost to ensure that these women get treated. So again, we need more funds, because how we're doing our work in terms of accessing them and bringing them for treatment and creating awareness, and also enrolling them to this Mabinti Center, we need funds, not only to create awareness, but ensure that we get to train them as part of the economic activities. Next slide, please. So we also need to link them with trained, either current trained women or former untrained in their local, to form a local enterprise group in their community. But also, as I said, one of the challenges is to access capital. So how can we link them to whether it's NGOs or government bodies or CSOs, so that they can receive not only for the training, but also they can receive capital for them to grow and expand their businesses. Again, the use of ambassadors I've mentioned, to really use these ambassadors to be able to reach more women and demystify fistula in their community. Next slide, please. I'd like to say thank you very much. I will want to then invite Professor Oluwayesimisi to then continue with our presentation. Thank you.
Thank you. Greetings to everyone. Good morning, good afternoon. We have the position of the Institute of Social Work of Nigeria on prevention of fistula reoccurrence. Next slide, please. Next slide, please. All right, the Institute of Social Work of Nigeria is a professional body of social work practitioners in Nigeria. And basically, the institute is involved with licensing of practitioners, continuing education. It works with government to ensure standardization and regulation in terms of policy for the practice of social work in Nigeria. It also ensures that there's quality service delivery in the dealings of social work. Amongst its business is to ensure that we have trainings for all classes of social workers on the practice and of course on related issues. There's also always room for internship because the institute develops internship programs for field work and for practical experiences. Membership is generally by examination and by induction. Next slide, please. So where is the project? So the project is located in Osun State, and the facility is the Wellesley Guild Hospital Fistula Center. What does the Institute do in this regard with the project? Mobilizes for prevention of fistula, makes referrals and helps with linkages between the client and the facility for repairs, and does a lot of counseling, pre-repair and post-repair. Now, with the counseling, matters discussed generally are family planning, fistula prevention, treatment services and facilities that are available, and basically rehabilitation and reintegration so that reoccurrence does not happen, especially when the family is not totally involved and the community is not involved. So with counseling, all this comes to place so that the individual can return to normal life. Next slide, please. So why the project? Why the strategy? Well, we know that when people are repaired after repairs, they come back. Sometimes they come back with worse cases and worse situations because the understanding and the meaning of rehabilitation and reintegration is not clear in the community and is not even clear to the individual. So what people do generally, community-based organizations, individuals, what they do is to give, upon discharge from hospital, from the facility, the individual is given some tools, sewing machines for tailoring, hair dryers for hairdressing, and a few other things like wrappers and some money. But again, the women return with fresh cases because they have not been properly reintegrated. They have not been properly rehabilitated because we know that just cash and wrappers would not mean rehabilitation and it would not mean reintegration. And in some cases, the husbands collect these monies and even collect the tools and sell so that the family can feed. So why is the need for us? When we looked at it as something that must be a continuum, something that must be carried out from the beginning. So we are looking at prevention. After prevention, what happens? In cases where they occur, there will be repairs. And after that, we come to rehabilitation and reintegration. That is a complete idea, and that is what the Institute has carried along with for fistula. Next slide, please. So what have we done? What have we done? We have looked at from admission, taking history, to identify the real problems. And when these are properly done, there is a stratifying of the categories that are from the information gathered in the crowd that has been gathered. Who are those for rehabilitation? They are treated that way. So those who need socioeconomic support, they go that way. Those for further medical support, they go also that way. And those for reintegration, How do we work with the families? How do they go back to normal life in society, in their communities? So counseling goes on there. And then those who need both rehabilitation and reintegration, what happens? Skills are given to their skills are developed, or their capacities are built through these skills development centers so that they can live normal life and progress. Next slide, please. So what are our successes? Next slide, please. What are the successes? Do we have successes? Do we have challenges? Yes, we have challenges. One challenge, basic challenge, is that there is no cohesion. Something is missing between the centers and the hospitals and the communities. So there's a lack there. There's a lack of connection, and that has to be, so it's a major problem for us. The next thing is that the opinions of people on rehabilitation and reintegration differ, and so there is no clear-cut understanding of rehabilitation. What again do we have? And rehabilitation and reintegration. And of course, the social workers. We have social workers in the hospitals, but they are missing when the real social workers who should work outside are not working together. So hospitals should have real social workers, not just medical social workers alone. So the successes, what have we recorded as successes? Next slide, please. What do we have as successes? We have been able to sensitize people that the people did not initially know that and did not believe that there are fistula problems, but now we have. So what do? ISO is working with the Nigeria, or worked with the Nigeria project and government, and we have come up with a strategy that would work for the people. Especially, there's a template on how to take notes, how to work pre-counseling, how to do pre-counseling, and after repair, what goes on. So there is a template. Other things that, next slide, please. Other things that have happened is that we have also seen work in the, we have also been able to work with communities, to work with individuals in communities. We have been able to raise the client as advocates. We have also been able to raise the family as advocates for the prevention and reoccurrence of fistula. So if you look at the slides further, you see the pictures of some cases where the husbands are taking charge and the husband doing further counseling and doing further advocates in the community. Thank you very much. Can I hand over to Safe Motherhood ambassadors?
Thank you very much. This is Healing Hands of Joy from Ethiopia. My name is Masalet again. Next slide, please. Healing Hands of Joy is an organization that's working with the vision to eliminate obstetric fistula in Ethiopia by ensuring all women achieve safe motherhood. Next slide, please. And we work, our work includes prevention, reintegration, and identification. So in the prevention aspect of our work, we train our safe motherhood ambassadors to become promoters of safe institutional delivery, prevention of obstetric fistula in the respective communities, particularly speaking to pregnant women, expecting mothers, and really helping them understand how easy it is if they were to prevent obstetric fistula, and learning from their own experience. So the prevention aspect is much more focused on the community level of our work. The other one is reintegration. So we receive these women, they come from the treatment center, and we receive them and they live with us for up to 16, 17 days. And in that time, we work on their rehabilitation and also their reintegration. So we make sure that they are now in a better place to be rehabilitated, depending on how severe their fistula was and how we can help them reintegrate into the community successfully. And the other part of our work is the identification part. We use our Safe Motherhood ambassadors and our community outreach program to address the issue of case identification, because there are a lot of women who still have not had a chance to be treated for fistula and not knowing where and how. So identification is another pillar of our work. Next slide, please. We work in 4 regions of the country, in the Tigray region, in Amhara region, in Oromia, and the southern region. So as you can see in the map, these are the places that we're working in. We started our work in 2010 in Tigray, then expanded in 2015 to 2 other regions, and now in 2021, we have expanded into the Oromia region. Next slide, please. And our Safe Motherhood Ambassador program is a holistic program. We help our Safe Motherhood ambassadors rediscover their joy and their self-esteem. And our key components, the key components of our training includes the maternal health education, so that they understand what fistula is, that it can be prevented, it can be treated, and at the same time also what are some of the methods they can use as family planning methods. So some of the things that we focus on under maternal health education is in that area. And then there is the income generating skill training, and also the provision of micro grants to start up their business. So what is it that they are interested in? What is something that can help them create income for their family and for themselves? That's the second part of our training. Then, of course, there is the psychological and spiritual counseling that we provide for our women. As you all know, these women have gone through a very difficult time and really needs as much psychological support and spiritual counseling they need, and that is one service that we provide. We don't stop there. As you all know, not all the women treated are successfully cured. Some of them will need to live with some kind of incontinence for the rest of their lives. And we do also focus on that and make sure that these women are also taken very good care of, meaning going back to where they are and really helping them reintegrate successfully, even though they're not fully cured. So our Safe Motherhood Ambassador program helps these women turn their greatest shame into greatest strengths. And one living example is Aliman sitting next to me, from whom you will be hearing soon. So one of our Safe Motherhood ambassadors are expected to reach about 94 other women with life-saving maternal health education. Next slide, please. So what have we achieved since our establishment? So we were able to rehabilitate and train 2,352 women as Safe Motherhood ambassadors. And we were also able to reach to 1,730 male family members. So the male family members program is including the group understanding and counseling as to what these women have gone through. The male family members, as you know, in countries like Ethiopia, the support of men is very critical, especially for women who have suffered from fistula for quite some time, and going back and really successfully reintegrating might depend on the kind of support that she receives. Therefore, we reach out to the male family members. It can be husbands, it can be father, brother, uncle, whoever is living close by and can really help these women successfully reintegrate. So our focus is also addressing the issue of the engagement of male family members. And these male family members are also ambassadors in helping us spread the word about the prevention of obstetric fistula in their respective communities. And the other area is the new case identification. As you can see in the picture, and we were able to identify over 500 women. By we, I meant our Safe Motherhood ambassadors. After the training, they would go back and make sure they find the women who have not had a chance to be treated and make sure that they do get the treatment. So meaning guiding them to where the treatment is, how they can get there, And they make sure, they physically bring them to the treatment center and help them be treated. Next slide, please. And the other aspect of our work again is the microloan or the economic support that we provide. We were able to support 1,265 women with income generation activities so that they will be earning some money in terms of income for themselves and for their family. So it can be providing them with livestock. It can be providing them with some basic selling goods that they can sell and make money. It can be poultry, any kind of business that they choose to do. We provide the support, including the training and the basic need of the startup funding. And the other thing is the participants, the community outreach work. We work with the communities, the pregnant women, schools, and also use the opportunity of addressing a wider population in terms of in places like marketplaces. So as you can see, we have been able to reach out to these many people with basic information about obstetric fistula. Next slide, please. Yeah, this is just one of our Safe Motherhood ambassadors who lived with fistula for 12 years. And she said this, and I felt like this may be something to share with you. Next slide, please. And now I have the pleasure of introducing Alima to you and my colleague who will be translating. His name is Tadele. Over to them now. Thank you so much.
Amma gaafa dhukkubni kun irratti naquunnamuudhaa jiru adda lafa waggaa 25 ciniinfuun bultii lama narra ture jennaan achumaan asitaalatti baatamee giseen jedhu mucaan du'aan na keessaa fuudhamee fincaan kun narra ture.
Her name is Halima Abba Milki. Halima said, I developed obstetric fistula due to 2 days prolonged labor at home, and I lived with it for 25 years without getting treatment. And finally, the family took me to the hospital, and I lost my baby. As well, the obstetric fistula occurred.
Leenjinaa kennanii nyaata koo jireenya koo naannoo qo'achii uffattuu masii bilbanii jarri kun na tajaajilanii na gabbisanii bareedeetuma tajaajilamee asii dhufee amma irratti naa leenjinuu kennanuu nama akka kam kee ta'e akka dhayitee ganda kee walitti sabasabdee jennaan sabsabaan.
What Alima said is after I heard the information about obstetric fistula from a local radio station. I automatically went to the treatment center where the treatment is free, and I got the treatment, the surgical treatment of obstetric fistula. However, my surgery was not successful. I was referred to Healing Hands of Joy, where I could get rehabilitation support training, and then the hospital referred me to Healing Hands of Joy, and I attended a 17 days residential rehabilitation support training, which covers the training covers 4 modules: health training, basic business income skills training, life skill training, and health training, maternal health training. So I attended this training here. The training was really nice. The feeding, the accommodation, the training modules, the trainers, everything was really nice.
Leenjisanii bareechanii tajaajilanii uffata keenya abaasaan daran uffisiisanii akka dhayitee biyya kee walitti qabdee sabasabdee akkuma humni si mudatee mudatini Dhayitee biyya kee walitti qabdee nama dhukkubsatee jiru akka barbaadee nuuf fiduu jedhanii asitti hoolaa qalanii nu nyaachisanii akkamitti nu bashannansiisanii biyya kootti galee dhaqee achi nama fidee kun akkamatee fayyee jira.
After the rehabilitation support training, in addition to the rehabilitation support training I received at Healing Hands of Joy, I was also trained as Safe Motherhood Ambassador, which I were expected to teach my community as well as pregnant women about the harms of home delivery, the consequences of obstetric fistula, the signs of obstetric fistula. I teach all this to my community and I started this working in my community. In addition to that, I identified 2 untreated cases of obstetric fistula. They have been diagnosed and referred to the treatment center. As well, they joined Healing Hands of Joy for the same rehabilitation support training.
Amma akkasiin egaa gara tarabbii fidee leenjitee isiin sun amma leenjitee adda eebbifamti. Jarri immoo mataa keenya bashannansiisanii reediyoo gaarii nu bitanii caammaa gaarii nu bitanii borsaa gaarii nu bitanii.
The training, the support, the reintegration support at community level was really nice. In addition to my work, Healing Hands of Joy supported me with reintegration support. The reintegration support includes an economic empowerment. They bought me 3 ships to start my small business to liberate myself economically. So this is all about my presentation.
Galanni keessan hin badinii, galanni keessan jiraatu, Rabbi sinnaaf jiraachisu, galatoomaan jedha.
Thank you all. God bless all of you. Done. Thank you.
All right, thank you very much, the team from Helping Hands of Joy. That is great. We will now transition to the director for the Momentum Safe Surgery Project, Dr. Vandana Tripathi. Vandana, the screen is yours.
Thank you so much, EMA. Thank you to all of the panelists for your presentations. You've shown us very practical ways that rehabilitation and reintegration services can make a difference for fistula clients. I especially want to thank Alima for sharing your personal experience, showing not just reintegration, but triumph. You inspire and motivate us all. Thank you. Over the past 15 years, with USAID's support, Engender Health has built capacity for fistula care in many high-burden countries, as you've heard, directly supporting more than 45,500 fistula repairs. For the vast majority of these women, the fistula was successfully closed. Many of these women have returned to their communities, but many others continued to experience significant challenges after repair. Through this work, we've seen the value of the holistic approach you've been hearing about versus just focusing on that surgical procedure itself. Closing the hole does not close the case. Women who have experienced fistula have many other health and psychosocial needs, as you've been hearing. Our own research has shown us, for example, that women who experience fistula also have significantly higher risks of experiencing physical and sexual gender-based violence. Our research has also shown that the actual mental health and physical health burden of disease associated with those difficult deliveries that lead to fistula, that burden is much higher than has been previously estimated globally. Therefore, our programming has always focused on ensuring that we're strengthening systems, health systems, but also community systems for an integrated response. One example being ensuring that fistula clients also receive family planning counseling and access to their chosen contraceptive methods, recognizing that voluntary family planning actually is a crucial part, right, a pillar of preventing the recurrence of fistula in women who've already gone through so much. Next slide, please. The slide you see that you'll be seeing shortly, here we go, thank you. It provides an overview of our current USAID supported project that is working to strengthen holistic fistula care. This is Momentum Safe Surgery in Family Planning and Obstetrics, part of the larger USAID suite of Momentum projects. In this project, we're working to strengthen fistula prevention, treatment, and support services as part of a larger initiative to increase the availability and uptake of safe and appropriate surgical obstetric care, family planning care, and of course, fistula care. In this project, we're also moving past prior capacity building efforts, expanding them to focus on strengthening local capacity to integrate interventions for rehabilitation and reintegration to ensure better outcomes for fistula survivors. Our goal is for country institutions and community-based organizations to take up this holistic, integrated approach and both sustain and mainstream rehabilitation and reintegration interventions like the ones you've been hearing about today into the routine healthcare delivery systems of these countries that still face a high fistula burden. Some of the panelists that you've heard from today, such as MAMA, LLC, and the Institute of Social Work in Nigeria, are already beginning to work together in momentum-supported efforts to build this kind of local capacity. Like all of our panelists, what they're showing us is that fistula care can extend far beyond the operating theater into care that meets those many, many other needs of women who've experienced fistula. Through this project, we certainly hope to increase awareness about issues like the recurrence of fistula, which is all too common among previously repaired women if they don't have access to ongoing health care and support, to increase community involvement in fistula prevention, but also in supportive reintegration, like the social immersion approach you heard about from Mustafa, and to increase actors' mobilization to really pull people together to recognize the growing crisis of iatrogenic fistula that Bridget mentioned, fistula that's actually caused by unsafe surgery. But in Momentum Safe Surgery, one of the things we also want to do is to connect local actors across countries, those local actors who are providing holistic reintegration and rehabilitation services so that the local lessons, the best practices, the tools that you've heard about today can be shared broadly across the countries tackling their fistula burden, and so that rehabilitation and reintegration can be front and center in the world's fight to end fistula by 2030. We are therefore looking forward to supporting a community of practice focused on rehabilitation and reintegration that can, for example, develop guidelines that countries can adapt and adopt to support holistic fistula programming. My colleague Yame FM will share further information on this idea and how those of you who have joined us today can join this effort as well. We look forward to working with all of you to show how countries and community-based organizations can collaborate and provide the kind of comprehensive interventions that can be just as important as medical treatment for women with fistula to heal, to thrive, and to live full lives with dignity. I thank you all for joining us today, and I'll hand it back to my colleague to lead us in a question and answer period. Renee, thank you.
Great. Thank you so much, Vandana. Really appreciate it. And I'd really like to thank all of the speakers and all of the participants for this engaging conversation. We'd like to turn the first question over to you, Brenda, from CCBRT. And the question in the chat was, since not everyone has the skills to do small businesses, I would like to know if you have a training component to help the women carry out their small businesses. Over to you, Brenda.
Thank you very much. And I can now hear you because when I was doing the presentation, I couldn't hear you. So I was just hoping that
Thanks so much.
We do. Thank you. So I just hope you could hear me. Asante. So absolutely. Not only we provide the training during the time they're with us, but we continue follow up with them for the next 6 months, and even sometimes beyond that, just to make sure that we support them. And yeah, so I can say, I guess I've answered the question. That's yes, we provide the basic business training, and not only during the training period, but also the support afterwards that we make follow-up.
Thanks so much for that, Brenda. That's really helpful. And I guess maybe, one other question I would ask is in that training for business, do you teach the women how to bank their money? I'm curious about that.
Yes. So and sometimes we do even invite banks just to come. We actually have a local bank which and even a very basic way how to manage their finances. So everything, as I said, most of them, they're not, they didn't receive formal education. So even you have to really tailor that training that will make sense to them. It's not something that you can, it really has to be very well tailored. It's not one size fits all. It really has to make sense that they understand. Yeah.
Great. Thank you so much, Brenda. I now have a question for Professor Obashoro-John, sorry. Who should constitute the ideal holistic biopsychosocial teams to address the various needs of women? So what members should be on that team? Professor Obashoro-John?
Okay, I can take that if she's if you're having a connection problems. Yes, for that kind of psychosocial support for rehabilitation, and then it's a range of people that have to be part of that. But certainly the key people there should be counselors, social workers who understand how to interact and how to work with this with the client. So they have to be social workers. But you also have to have people from the communities, also where the client comes from, as well as people from the government. You cannot rule out government participation in this, in the process of determining and guiding and providing a good transition for the clients from the facility back to the community. So it's a range of people, and we'll be talking about this, and it is part of the criteria that the technical working group, which we'll discuss shortly, would be taking on. So just be patient and we'll discuss more on that. Thank you.
Great. Thanks so much. And I'd like to kind of pivot back to Meselek and ask if you had anything to add to the previous question.
Yes, to the question in terms of the economic support.
Yes, please.
Add about the training that is incorporating the basic understanding of what income generation activities could be. Like, for example, these women living in the rural parts of Ethiopia might be having some kind of experience in buying and selling things. It could be eggs, it could be vegetables, it can be anything. And the other very important part is, again, the culture of saving. These women have never had any kind of saving, leave alone a bank account somewhere and putting some money in. So we encourage every penny that they save, because that is what is going to make the change and the difference at a later time. So saving and really start building on what they already know are two very important things that we try to address. Thank you.
Great, thank you so much. And we have a question for Jessica. Jessica, what are the minimum resources a facility would need to identify and to have to be able to successfully do the physiotherapy and rehabilitation work?
I think from a very minimum viable product, we need individuals, healthcare workers who are interested and willing to do the learning to carry out the work. We think that it is incredibly helpful to have a private treatment space where a physiotherapist or someone who is doing physiotherapy informed care can be working one-on-one with clients. We've had it it's been very beneficial to have larger space that can be used for group classes. And there are a few key things that have been useful in our work that have included exercise mats that can be used so that people can get down and onto the floor a little more comfortably. And actually exercise pants or leggings. That has been something that I think maybe people aren't necessarily thinking of as the typical supplier equipment, but that has proven to be very useful because it helps people feel more free to move, to do, stretches and exercises in different directions. Beyond that, there are many basics that would be available at other facilities, such as gloves and absorbent pads and so forth. But I think that there are certain types of equipment that we very much can do without by putting an emphasis on exercise health education and really good quality training of the staff.
Great. Thanks so much for that, Jessica. And maybe I'd like to ask a more general question for the panelists. And maybe Brenda, you can start with your answer first. How successful can a support group for fistula survivors in their communities reduce the stigmatization and improve the prevention of fistula? Are there any best practices that you can share? Please go ahead and unmute yourselves to answer.
You were breaking off a bit, but I hope I got the question of the importance of having, is it group sessions
yes.
for reintegration?
Yes,
okay.
Support groups in the communities.
Yeah, absolutely. They're very important. And I actually loved Mckinney, who talked about the role of men as well and how critical it is. I mean, we have some women who the reason why they stayed more than 10 years without receiving treatment is because they didn't get permission from one woman who was 65 years was waiting for permission from her son. So again, the role of men in treatment and prevention is critical. What we have here at CCBRT, we actually have, before they go home, whilst they're receiving treatment here, we have what we call group sessions. And we have a place where we call Mandala Matumaini, which is a place of hope. There's a lot of storytelling, which most of them, they come, they think their story is the worst story, and they hear another story and they're thinking, oh my goodness, mine actually is not that bad. So that has been so powerful. But the other thing is when they go back home, because they have this network of ambassadors, they also become ambassadors themselves to try to create awareness and to spread the word. And they actually, other people in the community now believe, okay, because they have to travel quite far to come for treatment to CCBRT. So it's always, it's like oh, okay, this is actually true. So you can actually go and come back safely treated. So that is one. But the other thing is part of a support group as for those who have now got treated, for those who received the economic training. So for example, if they had joined Mabinti Center, because it's not all of them joined Mabinti Center, also support each other in terms of materials, in terms of just skill set support. So it is actually quite crucial to keep that network using the ambassador, because the ambassador in that community will know hundreds of women who received the treatment as a support group. I'll let others as well respond. Thank you.
Great. Thanks so much, Brenda. Mckinney, would you like to respond to that as well?
Yes. Thank you again. In terms of support group, again, the male family members being primary support group for the women individually, but then community structures. There are already existing community structures in their respective communities. So our role then to facilitate the successful reintegration of these women is then based on what we can do at the community level and who in that specific community is able to provide the support for her reintegration. So for her income generation program and for any kind of follow-up in terms of her health, because some of these women would need to come back for some kind of treatment follow-up. And the other thing is, again, when they meet here at our centers, they become friends with other Safe Motherhood ambassadors. And when they go back home, partly because of the toolkits that we provide, which has a cell phone as part of the toolkit. They would keep in touch with each other. Now they have a friends group that they can be interacting with. And the other thing is everyone at our center is available at any given time whenever they need any kind of support. So they can call any member of our staff members and then really raise their concern if they have any. And because our team is going to the communities to do the prevention work and all these other follow-ups, it's easier for them to reach out to our team as well. So it's support structure, support groups. I cannot emphasize the importance of that enough. Thank you.
Great. Thank you so much for that. That's really, really helpful. I see that Dr. Abosh or John is back. Are you able to speak?
Yes.
Oh, wonderful.
Yes.
Thank you so much. One of the questions that's come into the chat, and I think we could probably spend a whole webinar on this question, is how do you measure reintegration and rehab? How do you know that it's worked? And I'm going to start with you on that question.
Thank you very much. How do we measure and how do we know it has worked? It has, we have been able to measure by the number of people who return to the facility, one, for checkups. So after a series of counseling and supporting the individual who has been treated and who is back to normal life and who probably wants to have more children, they come back to the same facility and we see them there. So we are able to measure that some things are happening. Secondly, we're also able to measure by the number of family members who have become, in quotes, supporters, advocates, and ambassadors of some sort for fistula prevention and reoccurrence. We do know that the initial has always been a problem. Because the initial is a problem, the problem has now been solved. Now we don't want people to come back with the same problem. So a lot of counseling, a lot of training, a lot of training for volunteers who are not really social workers, but who have now become volunteer social workers. And these ones are also working to ensure that things, these people, these repaired girls and women are living normal lives in their societies.
Thank you so much, Professor. Really appreciate that. And Mustafa, maybe you can talk about how rehabilitation and reintegration was measured in Fistula Care Plus. We'd love to hear from you. All right, maybe perhaps we can move on. And if Mustafa has a chance, he can come back in. One question for you, Jessica. Can you talk a little bit more about the challenges that you experienced in implementing the task shifting and task sharing program?
Yes, so I saw that question come up. I would say some of the things that we encountered that have been issues have been really advancing the perception of physiotherapy as a valuable service and really as powerful contributors to the holistic team. And I think that that was true for physiotherapy broadly, and then became even more of something to champion and a challenge to overcome in the context of fistula care when it was more specialized on women and gynecologic needs. Beyond that, some of the basics like appropriate referrals, staffing, and communication between different providers were some of the other challenges.
Great, thanks so much for that. Really appreciate hearing that. And thanks so much for sharing. One final question for Meselek, and I just want to let everyone know that in addition to a recording of the webinar and a copy of the slide deck, we will also send everyone after the webinar a written Q&A so that you will have all of the questions and answers in a document to read. So thanks very much. My final question for you, Meselek, is what are the chances of a fistula survivor living a normal life without discrimination, stigmatization after therapy and full reintegration into society?
Well, thank you. The chances are that they live a full life, successfully reintegrated in the community, if we are really addressing the needs of rehabilitation and reintegration. Because when these women come, they consider themselves as someone who's been cursed. For some reason, they've been cursed, and they look at themselves as someone who is less than a human being. They come with a very low self-esteem, and they think they're just the only ones that this is happening to. So when they come here, their eyes are open. They meet other people. They do see the care and love that they're being provided because they matter. It's not something that they have brought on themselves. It is something that can happen to anyone, anywhere. So helping them understand that, really increasing their self-esteem, and then when they go back, equipping them with what is needed in terms of training, understanding, and then again, giving them a responsibility and giving them the chance that they can make a difference once they go back to their communities. They can prevent obstetric fistula based on what they're understanding and first-hand experience, so that when they go back, these are then promoters of safe institutional delivery, safe motherhood, as their name indicates. So it is a very successful program that needs to be applied. As you know, I mean, treatment on its own is not the end of the issue. Rehabilitation and reintegration, as much as possible, needs to be emphasized because it makes a difference in the lives of these women when they go back. Thank you.
Great, thank you so much. Mustafa, did you want to comment on that as well?
Well, no, how to measure the effectiveness of the reintegration.
Yes.
The number of women who return to normal life, resuming activities they had before. It is a process. I would like to say that it has been noticed that visiting women who have been isolated for a long time are shy and stressed at the start of the program, but gradually they free themselves and finally have a smile.
Oh, thank you so much for that. What a wonderful way to close out the Q&A answer session. Thank you so much for everyone. And I'm going to go ahead and turn this over to my colleague, Ieme FM. Over to you, Ieme. Next slide.
Thank you very much, Renee. Now we have come to the point where we will have to be looking at what would be next for us in here. And so I'll be taking you through the process and things for setting up a technical working group for fistula communities of practice. Next slide, please. Yeah, so for us, I'll be looking at the need for a technical working group. From the questions that have been asked and so on, you can see clearly that there's so much, you know, there's a myriad of needs and things that we have to do to be able to accomplish this component that will then provide us a holistic approach to fistula intervention. Next slide, please. So first of all, in the discussions that came up, and in one of the questions, we realized that there is a need to harmonize language. When we say rehabilitation and reintegration, what do we mean? Would that be a common understanding across the fistula space, you know, so that everybody knows and understands that when you're when you're implementing a program on rehabilitation and reintegration, these are the main components that you have to follow. And so we'll then go on to develop a template for protocols around the harmonized language so that we are all speaking the same thing. And then we'll then provide guidance for programming. This is what the technical working group would be doing, and that's their responsibility. And after that, they organize sessions to share ideas and global best practices in the field of rehabilitation and reintegration. Next slide, please. And so what would be the approach for setting up a technical working group? We will be looking at constituting the team, and to constitute that team, we want to look at identifying organizations in the intervention space because we don't want it to be individual based. It has to be organization based, because that's where you get, where you're involved and able to implement whatever strategies you have, and the experiences you bring in would be helpful. So we want to identify key staff in the team, in the organizations that we want to become members of the technical working group. Then we also have to look at the government component, because certainly for mainstreaming and for sustainability, the government is the resting house for them. And so we need to look at government and departments in government or ministries that are capable of managing this process, so they would manage it in different countries. And then, of course, the civil society, that includes the social working groups, the CBOs, and other groups who form the foot soldiers. They are the ones where the rubber meets the road. They are the ones there doing the country, doing interactions and so on. So we also need this group of people in the technical working group. Next slide, please. So in developing the technical working group, what will be the next steps there? We want to see that interested parties should send an email, and that email address is to me, and it's on the screen. Please send email on there. Once we get the email, we will go ahead to compile a membership list, and then we will formally send out invitation letters to for a meeting, and on a date for that to be determined, where we will then inaugurate this technical working group. And this is going to be a group that would have in what I call membership from across board: international organizations, government, civil society groups, and implementing partners. And so this would be something that we can use to be able to move this and come out with a common language and a common understanding of rehabilitation and reintegration. We look forward to working together to create a new paradigm in fistula rehabilitation and reintegration programming. And so I'll be very excited to begin to receive emails from people, and so we can form this technical working group, and that would be a step forward. Thank you all very much, and I'll hand back over to my colleague, Dr. Renee Stafford.
Thank you so much, EMA. That's exciting work, and I'm really looking forward to hearing more about this. What I'd really like to do is to thank all of our speakers and presenters, with a special thanks to all of our participants. Your participation is greatly appreciated, and really also want to thank you for spending your valuable time with us today. We really appreciate it. Next slide, please. We have some resources to share with you that you will see. And if we can go ahead to the next slide, that would be great. We have some resources here on the screen. The full slide set will be available to you and will be shared with you along with the webinar recording after the webinar closes. In addition, as mentioned earlier, we will share a written transcript of the questions and answers with you, along with the webinar recording and the slide deck. Of note, there are some questions in the chat that have not yet been answered. We will make sure that we get answers to you for those questions, and they will be included in the written transcript. In addition, please pay attention to that very important first bullet point here. Please take the time, if you would, to fill out a very short post-webinar survey for us. The link to that will be included in the slide deck, but it has also been placed in the chat for you. We really do appreciate your time, and we'll find this very valuable. And we really want to thank all of the excellent organizations and presenters for their work. And once again, we'd like to thank all of you for your participation and sharing your valuable time with us. Thank you so much.
Thank you.
Thank you, everyone.
Thank you.
Thank you, Renee.
Thank you, everyone.